Thank you. I wanted to spend just a few minutes this evening talking about what we think, and I'm going to emphasize that because nobody has seen the bill that I understand we're supposed to vote on tomorrow morning that spends almost $700+ billion. We've not seen the bill. We've not seen report language. And I can assure you that this senator isn't about to vote on this bill till he's read the bill. And we will do due diligence to do that if we ever get a copy of the bill. But I wanted to talk about a couple of things that are important that we think are in the bill. And it has to do with health care. I have a little bit of experience in that. I've practiced medicine now for 29 years. And I find parts of this bill that I know when it's explained to the American public, they will agree with me. It's ludicrous. And let me tell you the first part of the bill. There's $20 billion in this bill to pay hospitals and doctors to buy health IT. Now, at the beginning, you'd say, well, what's wrong with that? We want electronic medical records. We want to see the benefits that come from the economies of scales and the increased productivity that comes from IT to help us in healthcare. Where this bill doesn't understand what is happening out there is doctors will buy health IT and hospitals will improve. They all have health IT right now, by the way, will improve their health IT once there's a program out there that is interoperable with the rest of the program. And the reason doctors aren't buying programs for electronic medical records has nothing to do with a lack of money. It is this very simple reason, is they know if they buy it now, they get to buy it again. Because none of the computers in health IT talk to each other. They won't talk. And that's called, the way to make them talk is called an interoperable standard. And for a good example, for you to compare, think about before we had ATMs. How did we make an ATM where you can go anywhere in this country, if you've got a credit card that allows you to get cash, and go into any ATM in this country and get cash out of it? How did we do that? How did ATMs come about? They came about because the private sector, the banking industry, created an interoperable standard first. Once they had the interoperable standard where every bank could make sure they could talk to every other bank, they put in ATMs. And all of a sudden, voila, anywhere in the world today, if you've got money in the bank and you have an ATM card, you can get money out of the bank. They didn't build the ATMs first and didn't have the government buy the ATMs before they had the standard set. Well, people say, well, we've taken care of that in this bill. We're going to have the government decide what the interoperable standard is. Well, the government's been working for 6 years to develop an interoperable standard. They're at least doing it through a private consortium now, and 80% of that standard has been accomplished. It will be completed in 2011. But it won't be completed the way this bill's written, because we're going to pull it all back from this public-private consortium, and we're going to have some bureaucrats at HHS decide what the standard's going to be. There's a lot of problems with that. One is nobody at HHS knows that information. Number two is everything that's out there in the market today is now put at risk, so you're going to absolutely stop private investment in this area that is so much needed. So what we're going to do is we're going to allow bureaucrats to decide what it's going to be. We're going to eliminate companies that have great ideas because they're not going to be on the mix. And we're going to set a standard that's not going to be the best standard. The way the HHS has it set up now with a private-public consortium was a poor way to do it, but at least it's got it 80% of the way there. We're going to backtrack on that. Now, just so you know, we're so good at spending money, we've spent $780 million already of your money trying to get there that we're going to now throw down the toilet so we can start over and have bureaucrats exactly decide what the standard's going to be. Well, I will predict to you everything else we do in IT in the federal government, 50% of the money we waste. That's what our studies show. We waste $32 billion a year on IT programs that never work out of a $64 billion budget for IT programs alone. So we are going to waste a 1 ton of money. But that's not really the important thing. In this bill, we're going to give every doctor in the country, no matter how much money they make, if they don't have an electronic medical record, we're going to give them $60,000 to buy an electronic medical record. Now, it would seem to me that with the income of the average physician being over $200,000, that the last place we want to give $60,000 to buy a piece of software that isn't going to work, that's going to have to be replaced anyway, is to those that are in the upper incomes in this country. But that's probably not as important as we're going to give for-profit hospitals and the profitable nonprofit hospitals $11 million each to buy electronic medical record software that still won't talk to the doctors who bought and we gave $60,000. This total cost of this and what we're doing is going to be in excess by the time all the problems are solved and all the defects are figured out and all the wasted money is going to be $100 billion. This bill is going to waste $100 billion. Now, tell me for a minute why we would give some of the most profitable companies in this country, the for-profit hospitals, and the not-for-profit hospitals who last year made in excess of $6 billion. That's the not-for-profit hospitals, made in excess of $6 billion besides doing the charity care that they did. Why are we going to give them $11 million each to accomplish something that can't be accomplished? And I'll tell you why we're going to do it. Because some congressman or some senator said the way you solve this problem is throw money at it. They haven't thought it through. There's been no development or recognition of what is really needed, which is an interoperable standard. Now, what should we have done? 7 years ago, when we started down this process, there were 3 great programs out there. One at Mayo, I'm talking big programs, one at Cleveland Clinic, and one at Kaiser Permanente. What should we have done? We should have bought all 3 of those, created an ability for those 3 programs to talk to each other, and then given it away. We would have spent about $20 or $30 million, maybe $100 million, maybe $200 million, but not $100 billion. So again, Washington has messed it up. The very thing we're hoping to fix, we're going to ruin. And by the way, as we do it, we're going to waste $100 billion. And 20 or 30 billion of that total is in this bill. The other interesting thing is none of this money starts rolling out until the middle of next year. I'm told I have just 1 minute left to speak, so let me spend the rest of my time, and I might ask unanimous consent for 2 additional minutes.
Without objection.
That's just one of the problems with this bill. Let's talk about the big problem with this bill. As a practicing physician, I know what physicians are taught. Here's what they're taught. First, do no harm. Second, listen to your patient, and they will tell you what is wrong with them. Third, if it's already been done, don't do it again. That's what they're taught. That's the premise. with that comes years of experience, clinical judgment, and in-depth knowledge about people and their disease. In this bill is a statement that says, we're going to develop, through a large slush fund at Health and Human Services, a model called comparative effectiveness. Now, there's nothing wrong with comparing effective outcomes. There's nothing wrong with trying to use clinical data to direct us in a better direction. But that's not what this is about. This is comparative effectiveness to control costs. And I want to warn the American people tonight that if this bill goes through, we're well on the way to absolute government control of the patient-doctor relationship in this country. Because we're going to assume that there is no way that a doctor can make a better decision than a computer can. And I want to give you two examples that happened in the last 5 years in my practice alone. Two people who came in who had no clinical signs, none, had no indications other than what me knowing them for years, me to develop a suspicion that something was wrong. They didn't come for the complaint. Their complaint was something else. I ordered MRIs on both of those patients. They were both denied by their insurance company. I arranged for both of them to get MRIs. Guess what? Both had deadly brain tumors. They never would have fit in the comparative effectiveness or the cost control mechanism that we're setting up with this so we can control Medicare costs. This is the first start for the government to start rationing the very care that it says it wants to give to the American people.
Senator's time has expired.
I'd ask in unanimous consent for one additional minute.
Without objection.
The American people better pay very close have very close awareness of this bill. Besides being a stimulus bill that isn't going to stimulate much, a massive move to limit, and if you're on Medicare today, or if you're 55 years of age, you better be plenty afraid of the language that's in this bill. Because it is setting up the basis with which the government will decide what kind of care you get. And we're going to use a chart, and if you don't fit in the chart, you're heck out of luck. You're going to lose the ability for clinical skills to make a difference in your life. And just go talk to the people of Great Britain when their cancer rates are half what ours are, cancer cure rates are half what ours are, because they don't have access to treatments that Americans have today. Mr. President, I'll be back to talk on this some more. I appreciate the chair and my colleagues allowing me the 3 extra minutes, and I yield the floor.